women who had been turned away, who later were indeed found to be having a myocardial infarct, where there was sort of this reevaluation, let's say, of what it means to have a heart attack for a woman. Hey, Betties. Welcome back to another episode of Better with Dr. Stephanie. It is me, your host, Dr. Stephanie Estima. And for those of you watching on YouTube, welcome to my new studio. You may notice the nice, dramatic, black wallpaper in the background. I hope that you love it as much as I do. And today I have a special presentation for you. I was recently asked by Oxford University to present to their staff, the doctors, some Rhodes Scholars, clinicians, researchers that are working on the Oxford Longevity Project, some of the differentials that we have to consider in the female population with respect to fasting. And I put in, as you might expect, I over-prepared for my talk with them. And I thought afterwards, I was like, I'm going to share this with my Betties. I want to share this with you as well. So we are going to, over the next several weeks, actually, I'm going to be sharing a little bit more of some of my thinking, my body of work, what I have been thinking about lately when it comes to health, metabolism, human optimization. So would love to hear your feedback on some of the content that we're going to be putting out over the next couple of weeks. Don't worry, we're still doing interviews with some of the world's thought leaders. But I thought, hey, I have this podcast and I would love to also share some of my thinking and some of the ways that I approach problems in terms of, in this case, fasting for women, some of the common hormonal derangements, let's say, that we might see, and how we might look at that. So I'm going to share with you my screen. For those of you that are watching on YouTube, for those of you that are watching on audio, this means absolutely nothing. So just bear with me. Okay. So for those of you that are watching this is going to be really useful for you to sort of see what we're referencing. So if you're listening to this on your audio feed, it's still absolutely fine. You're going to get a lot of great stuff, but you're also going to get some slides. And then we'll make sure that we have the references in the show notes as well. Okay. So this first slide, kind of funny. We have an on-off switch for a man and then all the buttons and dials for a woman. It's kind of tongue in cheek, of course. But we do want to be thinking about specifically with any tool that we are imparting or we're trying to implement, let's say, for women, we are far more complex in terms of our hormonal landscape. And even honestly, even the term woman is kind of vague, right? Because a woman is going to move, even the individual woman is going to move through different hormonal environments over the arc of her life, right? So we have the time in her life when she is pre-menstrual. We have, of course, her reproductive years. And then we move in her 40s, we're moving into perimenopause. And then in her 50s with, kind of the mean age, somewhere between 50 and 52 years of age, she's going to go through menopause. And then, of course, post-menopausal. So even in the individual, right? Even in the same individual, we're going to get a large variation in terms of hormonal composition and then what her vulnerabilities are as well. So, okay. So this is just for those of you watching, this is just my little intro slide. It's like, hi, I'm Stephanie. This is what I do. So podcast host, as you very well know, I also like to call myself a card carrying nerd, Duolingo aficionado, and my chocolate short ribs have been known to make grown men weep tears of joy. These are my little shticks when I'm up on stage, and then a little bit about me there as well. Now, of course, I came into this work. I came into fasting. This is actually what I'm originally known for, is talking about fasting and how these are how fasting is different for women, because almost immediately, this is back when I was in clinical practice, had a brick and mortar practice in Toronto, Canada, noticed that there was a pattern difference that emerged between females and their male counterparts. And it was more often than not, it was like we'd be running a nutrition program. There'd be a fasting component. Let's say maybe there's some ketogenic or some caloric restriction, like some kind of combination of the above. And we'd have like a husband and wife couple that were going through the program together. And of course, the guys would be kind of like strutting through the clinic going, man, Steph, like this is the best program since sliced bread. Like I have lost weight and my libido is back and I'm sleeping like a baby. And it was so much more often than not that, that husband was followed by, his wife, kind of slugging her feet, being like, man, like we're eating the same damn things. And like, I've lost a pound and this guy's dropped 20. So very early on, noticed a difference between men and women when it came to weight loss. And fasting, of course, in recent years has emerged as this like premier tool in healthcare, right? So many women, especially as it's related to weight loss, because a lot of women want to learn how to lose weight, have started adopting fasting practices with kind of a mixed bag of results. And I would also say as well, I've kind of noticed in this post-pandemic era, we can call it post-pandemic. I'm hoping, God, please, let's hope, dear goddess Isis, please, can we call this a post-pandemic era? In this post-pandemic era, I've also been noticing that it's not just about weight loss anymore. We are, at least I'm noticing that people are really interested in kind of like a deeper level of health. Like people want like deep cellular healing. And fasting, of course, can be a tool that we use in order to facilitate that. And so often, a woman or anyone who really wants to lose weight, they might go to their allopathic physician. And what does the allopathic doc do? Well, the only thing that really matters is calories in versus calories out without any, sort of consideration for female physiology, for female hormones, largely because they don't know anything about it. Menstrual cycles, phases of the menstrual cycle are not taken into account. And, these women will kind of leave those appointments feeling like, God, like what the hell is wrong with me? Like, why can't I lose weight? It must, or even worse, I've had many women report to me that doctors have kind of said to them, unfortunately, that it's like all in their head, which is kind of a form of, in my opinion, gaslighting, because it's not that it's the woman's fault. It's just the doc that they're seeing doesn't know what to do with them. So it kind of pushes it back on them. So that's sort of the first reason why I was really attracted to it. And when I started looking and digging into the research, it's getting a lot better now. But back in like 2016, 2017, it was like scant. It was like slim pickings when we were looking at particularly the female specific evidence and this female specific literature. So, fasting in women, very poorly studied. It's kind of patchy at best. And, with research is kind of the first step. Like we need good evidence-based research. And without going on a tangent, I'll also say like that word evidence-based, I know I just used it, but it kind of gives me like a little bit of a little nervous tick, because people that like to throw that term around often don't really have a lot of clinical expertise. So everyone kind of runs around the internet and says, evidence-based, we got to be evidence-based. That's not evidence-based. And it's like, okay, evidence-based or research, what the available literature dictates is it gives us information, right? In a very tightly controlled way. We absolutely need it, right? The the clinician's job, so the doctors and the practitioners, it's their job to take that information and apply it and be able to pivot when necessary, because patients are not lab rats. There's not there's not a controlled environment. There's not just one variable that's, let's say, being manipulated. So, the clinician who's going to be working with women needs to be up to date on the available literature. Let's say she has to be able to apply that information, that literature, to her patient base and have a good understanding of female physiology to be able to make inductive and deductive, let's say, conclusions based on what she's seeing in her patient population, and be able to pivot when needed. And this is, in the lecture that I gave at Oxford, this is really nowhere more best exemplified in and you'll see up on the screen here, symptoms of a heart attack and the differences in how that presents differently between men and women. And even when I was in school, I was taught, a heart attack is like shortness of breath, extreme chest discomfort or pain. It's like the radiating pain down the left side of the arm. And for a woman, that's not necessarily the case. She might present to the emergency room with a very bad headache, with indigestion or heartburn that's been going on for several days. And I think it's really only after there was like probably a tipping point of women who had been turned away, who later were indeed found to be having a myocardial infarct, where there was sort of this reevaluation, let's say, of what it means to have a heart attack for a woman. So we need to really be cognizant, and I think that it's getting better now, of the different clinical presentations of, let's, in this case, an MI between a male and a female. And since we're talking about MIs and cardiovascular disease, of course, the number one killer of men and women is CVD, cardiovascular disease. And even though women have a longer mean lifespan, let's say, than men, it's still our number one killer. It's not necessarily that we don't get it, but there's a phasic shift in when we get this heart disease or cardiovascular disease. We tend to get it later on in life, and it's usually somewhere between a 10 to 15 year gap between like the mean CVD age of men versus women. So there's a couple of explanations for why that is. One, obviously, women have a menstrual cycle for about 40 or so years. So it's like we've given a blood donation every single month for 40 years. So there's a lot of turnover. We have less iron as a result of that. For the women who have been pregnant, growing a placenta, of course, like being the process of being pregnant, having a placenta. We have, obviously men don't have a placenta ever at any point in their lives. And this is like a wound healing defense strategy as well. So when we think about, even just from a teleological perspective, men evolved to heal from wounds quicker, but with a cost. Women did not evolve. Women evolved to protect their offspring, right? So as a general baseline, you'll find that when you compare men and women of the same age, you'll often find that women will have a lower systemic inflammation, lower prothrombotic response, for example, between men and women. So women are sort of, we'll say, there's more advantageousness, let's say, of being a woman in that particular sense. The other thing, of course, obviously, with pregnancy is menstruation, which I mentioned just a moment ago, with, giving sort of a blood donation every month, but it's also very prevalent with women who go through early menopause. So women who go through early menopause, meaning like when they're 40 years old or younger, have a 2-year lower life expectancy compared with women with either a normal onset of menopause or late menopause, right? So data from the Framingham Heart Study suggests that a harmful cardiovascular risk profile may be more cause than consequence at the age of menopause. So there is almost like so all that to say, all that big jargon, all those words, all that to say is that estrogen does seem to in our reproductive years, estrogen does seem to confer a protective benefit for women while we are in our reproductive years. And so the women who are going through early menopause, let's say, who are sort of robbed of that protective effect of estrogen, that affects their lifespan, right? They have a 2-year lower life expectancy compared to other women. And that cardiovascular risk profile, right, is more causal than it is corollary, meaning that if you don't have that, let's say, that protective effect of estrogen, this might be causal versus just something that's happening alongside it as well. Okay, so one of the other things that I presented, which I thought was worth mentioning, this is something that I learned from Dr. Ethan Weiss, who was when he was on the show. We talked a little bit about this. is, and this is related to cardiovascular disease as well, is the clotting, like the rate of clotting differences between men and women. So one of the other things that I think is super cool. So obviously one of the big obvious differences between men and women is like the presence or lack of a menstrual cycle at some point in their lives. But the other thing that's really cool, Betty's, is that mammals, us included, have a remarkably sexually dimorphic liver. Okay. So this is where I start to my inner nerd is coming out now. Okay. So there's a tremendous signature difference between the genes that are turned on and off in the liver of females and males. And of course, where are clotting factors made? Well, they're made in the liver. And, Dr. Weiss was looking at, okay, well, is this like under the influence of estrogen? Is it under the influence of like sex hormones? And it turns out that, it's not those things. It's actually growth hormone. There is a sexually dimorphic pattern of growth hormone secretion. So what that means, and I'll put the 1984 Cell paper here. They called it the feminizing factor. But basically what they, described is men have a more, call it like pulsatile release of growth hormone with longer intervals between those pulses. And women have a much more continuous secretion with like shorter, very short intervals. Okay. So in rodents, you can actually inject growth hormone into a rodent in a particular way that can actually completely reverse the gene expression in the liver. And I laugh because I have so much reverence for the human body, and for how we are really different between males and females, even not even just the human body, but just even all the way down to the rodents, right? So in rodents, you can inject growth hormone in a particular way that can completely reverse the gene expression in the liver to make that liver more masculine, let's say, in a female rodent, and more feminine, let's say, in a male rodent. And so I think that that's like very important, not really discussed either. And growth hormone, of course, when we think about, some of the benefits of growth hormone, it's involved in maintaining muscle mass, and it's involved in all of these different things. So it is kind of important to note that there are some sexual dimorphisms that are beyond just menstrual cycle. And so that's what I do now, right? So as many of you know, you may have heard me on the show talk about the Estima certification program. This is why I now teach doctors and practitioners, right? These female-specific physiology, the clinical protocols, because we are not, as doctors, taught this. I was not taught this in my schooling. And so many of the practitioners that come into the program say the same thing. They're like, I did functional nutrition. I did all the courses, and they kind of gave us basic science. So even the courses that are out there today, and I'm not poo-pooing on any school, but of course they don't have this kind of dialed in, curriculum that's specific to female patients. And doctors and patients want protocols and tools that are going to help support their female patients. Or if you're the female client, you're like, I would like to go to a doctor who kind of knows a little bit more about my body and doesn't kind of look at me as like a small titrated version of a man, right? And of course, for women, as I mentioned, we have different seasons, right? We have different hormonal compositions over the arc of our life. And that leaves us particularly vulnerable to certain types of hormonal derangements. This is very true in perimenopause and as we're transitioning into our menopausal years. And from a clinical standpoint, and this is what I was telling the doctors and researchers at Oxford, we want to be educating. Not only we want to be educating the educators, we want to be educating the clinicians who are patient facing. And we also want to, empower our women, our beautiful patients, so that we can teach them a little bit more about their body. I can't tell you, if I had a dime, my grandmother used to be like, if I had a dime for every time I saw a car run a stop sign, I would be rich, And if similarly, if I had a dime for every time a woman would come to me and say, I've only started paying attention to my menstrual cycle in my 40s. Like, I'm so embarrassed. Why didn't anybody tell me this before? I would be rich just on that alone. So essentially, what we want to do is, if you're a female, even if you're a practitioner or patient, you want to be able to understand and respond to your female body or your patient's female body, help her respond to her body in the way that that female body requires and expects. Okay. So there's a requirement and an expectation from that body that is not a little man. Please proceed appropriately. Okay. So I was asked to speak on the differences in terms of response to fasting and females. And of course, as I mentioned at the top of this conversation, weight loss is a really big sort of draw, let's say, to why fasting has become so popular. It is very much a form of caloric restriction, which is going to result in at least transient weight loss. Autophagy is another reason. So autophagy, I like to explain it as like Pac-Man going after all the little pellets, right? You get the cherry, you get the ghosts, and then, you get all the things, and then you can move to the next level. Fasting also facilitates clearance of senescent cells, or what's often referred to as like zombie cells. These are cells that are just like kind of hanging around, but like doing nothing. I like to call, if you're in Canada, you'll kind of get this joke. It's like this, like the passport office right now. It's like no one's there. So, it's sort of like they're just kind of zombie cells, right? Like they're hanging around, like the office is still there, but there's no government officials in there. And yes, that's a direct knock on the Canadian government. But and I'm sure it's true in every country where there's like, you go to the DMV, like, oh my God, the lineup that you wait. Like I've been to the DMV, like the Department of Motor Vehicles. And when I lived in the States, I remember going there when I was living in New York, and I was like, oh my God, this is terrible. So that's sort of like what fasting does. It's like getting rid of all of the inefficient workers at the DMV or the Canadian Passport Office. And of course, it reduces, when you're fasting, you are going to help reduce systemic inflammatory pathways. It does augment or improve, let's say, longevity genes. So there are things like HDAC inhibitors. I won't get into this, but this is like histone deacetylase inhibitors. There's FOXO genes, which when we look at, let's say, centenarians and supercentenarians, they have kind of the optimal expression of these genes. And then, of course, it also helps with metabolic flexibility, which is kind of a, generally term. It's sort of a wishy-washy term. But basically, the way that I would define it is your ability to use an alternate substrate to glucose for fuel. So glucose, the molecule of life, right? Every single cell in the body uses glucose. But we also want to be able to use alternate substrates. So things like, free fatty acids, amino acids, and ketone bodies, et cetera, in order to generate power or ATP. And then the other thing, of course, that I've noticed clinically is that when a woman or a man is fasting, what we see is a clinical improvement, and they've been doing this consistently in a way that's like, manageable and reasonable for them to do over time, that we will see a clinical improvement in all markers of metabolic syndrome. So metabolic syndrome is kind of a constellation, if you will, of 5 main things. So if someone with metabolic syndrome is going to have an increase in blood glucose, so their blood glucose is going to be elevated. They're going to have abdominal obesity, or, if you wanted to state that properly, you might say an ectopic fat distribution. So for women, that might be excess abdominal obesity, like central obesity, like through the tummy. High triglycerides. So you have high tags, you have high, or rather low, high density lipoproteins, and then high blood pressure as well. And I think to qualify for metabolic syndrome, you need 3 of the 5. So fasting helps with all of that. The other thing, of course, that I mentioned before with growth hormone, when I was talking about the sexually dimorphic liver, growth hormone, as I mentioned, is known to help preserve muscle mass and bone density for my perimenopausal and menopausal women. That's very, very important. like many other things, like many other hormones, growth hormone also, the secretion, whether it's pulsatile or continuous, whether you're male or female, maybe another way of saying it, also decreases like pretty steadily with age as well. And growth hormone, we want that to be high because that is going to increase the availability. One of the bonuses of GH is that it's going to increase the availability and utility of fats for fuel. Okay. So exercise. So I've already, like, y'all know my bias, right? Like, I like to resistance train. I like to lift heavy shit. I like to, and I feel like I can swear with you. And I'll put a little E on this in case there are little kitties in the car listening with you, but I like to lift heavy weights. So exercise, and particularly resistance training, very potent stimulator of growth hormone. So is fasting. There have been some studies that have demonstrated that fasting periods, long, like, extended fasts, can, in some cases, double the growth hormone secretion. And of course, the net effect of that, at least initially, is to help maintain muscle and bone tissue mass over that fasting period. Okay. And then the other reason that I actually love fasting, not talked about enough, like I've talked about some of the physiology, metabolic implications of fasting, but I think this is me kind of getting back to my original roots as a neuroscientist and lover of all things brain and brain metabolism, is that there's like a dopaminergic reset from hyper palatable foods. So without going on, down a, kind of a vertical of, a rabbit hole, if you will, of, big food and bliss point, we do know that most processed foods do combine a kind of fat with sugar to make it, to release dopamine, right? Like it's going to release quite a bit of dopamine. And it's also going to produce, if there's a lot of sugar in it, you're also going to produce kind of serotonin as well. And what happens, of course, when you have such a high release of dopamine is that you remember exactly what you were doing right before the dopamine release happened. So that might be having a candy bar, that might be having, the Lay's chips, or, whatever, the pretzels or the cakes, the cookie, the cracker, the crackers, like whatever it was immediately prior. This is actually the basis for addiction, actually, is your brain is going to remember the activity that immediately preceded the dopaminergic release. And you are going to seek out and recreate, I should say, that situation again. And so fasting, from a nutritional standpoint, what I like about it is that it is a dopamine reset from hyper palatable foods, because it's not necessarily, so there's the hyper palatability. That's the problem. There's usually like caloric density with low satiety that also accompanies these foods as well. And then, some of the other things, like when fasting's done properly, it can also help reset circadian biology and augment sleep and improve insulin sensitization as well. And insulin sensitivity is actually a really important topic for women in their perimenopausal and menopausal years, because we become, as women, more insulin resistant as we age. And again, another word that's kind of nebulous. Like, what does it even mean to be, insulin resistant? When I was in school, we were kind of taught the lock and key model, where like insulin, there's so much insulin, it was like gumming up the insulin receptor, which is kind of an outdated model. When we're actually defining insulin resistance, there's like three sort of insulin response organs that we are kind of concerned with, right? One is the liver. One is the fat, or the adipose tissue, and then the third is the muscles, right? And insulin is going to signal, the muscle, the liver, the adipocyte, right, to take up glucose. Insulin also tells the liver, hey girl, you're okay, stop making glucose. So it's going to inhibit gluconeogenesis. And of course, the liver is female in my world. So insulin's gonna be like, hey girl, you can take a break making all that glucose. I see you multitasking and doing all the detox and all the things. So I anthropomorphize everything. I'm sorry. Like progesterone is a woman. The liver clearly is a woman because of the multitasking badass that she is. So insulin is going to say to the muscles and liver fat, take up glucose, take up substrate, please. Insulin's also going to tell, the liver, you don't need to make any more of this you don't need to make any more glucose. You're good. Okay. So an impaired ability to do either of those things in the presence of insulin. So muscles, livers, fat, taking up glucose, or the liver to be to have this inhibitory effect of gluconeogenesis is actually what we call insulin resistance. So it's kind of like in the presence of insulin, if your body is unable to do those two things, take up glucose or the liver to stop making glucose, you are insulin resistant by definition. And again, this is, I read a stat, I believe something like 88%, maybe I think the number was 88 or 90% of women, the population, not just women, are metabolically ill. When we talk about the US and Canada, Western Europe, this insulin resistance piece is approximately 50% of the population. Like every other person that you're crossing on the street or that you're riding on the metro or the subway with, they're insulin resistant. And it largely goes unrecognized because it's pretty much asymptomatic, right? It's not. When you're insulin resistant, you don't necessarily know it. Like there are some signs, when you've been insulin resistant for many years, if you're just kind of looking at the face, I'll kind of let you guys in on like a little bit of some of the observations that your doctor, if they remember, may be making, but like dark circles under the eyes is usually a sign of insulin resistance, for example. But for most doctors, it just slips through the cracks because, it's unrecognizable from just doing like a simple fasting glucose value, right? Because and we've had, Dr. Casey Means on the show, and I asked this question, and we'll put a link in the show notes to her conversation with me. It was a great one. I had asked her like, hey, like unicorns and sparkles and rainbows, like if you had a CGM, like she's, one of the co-founders of Levels, if you had a CGM that could do everything, like what would you have? And one of the things she was saying is she would love to be able to also look at insulin because you can have a normal blood glucose on a CGM, but your pancreas could be working like a mother to like the amount of insulin that your body has, like those beta cells in the pancreas have to release to get that glucose into a normal range, is like burnout. Let's say that pancreas is going to burn out if we don't do something about it. So CGMs are great. They give you a lot of data, but we also want to have an understanding of what's going on at the level of the pancreas as well. So essentially, someone who is insulin resistant, right, is because they can't get glucose into the cell. And then taking that a step further, they can't get glucose into glycogen. So glycogen is basically the storage form of glucose. And this is kind of like the major pathway. This is like the major problem because women and men, let's say, who are obese, let's say, like, or a type 2 diabetic, their cells are literally starving. It's not, and I will call my own biases out here. I used to think, before talking to enough experts and kind of doing enough research, that it was like these individuals were obese because it was like a lack of willpower, or they were just like eating yo-yos or whatever. I don't even think that's a thing. Like I'm trying to think of, what am I trying to think of? It's that like sandwich. It's like and it doesn't matter. Like a ho-hos maybe. Anyway, like they're just eating these like bad foods all the time. It's a lack of willpower and they're just like gluttonous. It's not necessarily the case. Obesity is actually quite a complex disease. In a healthy individual, 80 to 90% of consumed glucose that is not used immediately is stored as glycogen in the muscle and the liver. Someone who's diabetic, we have these processes that have gone awry, right? So we have elevated blood, like the first thing is that the liver is continuously producing more glucose, right? Through gluconeogenesis in the presence of insulin. And the second, obviously, is like less glucose is being pulled up into those muscles that are into, I should say, those muscles, into those organs like muscles, liver, and the adipocyte, which are primary organs for insulin. So overall, production of glucose is up and clearance is down, right? The other thing I will mention just about insulin resistance, like I could honestly talk about it, like just this one slide, I could stay here forever, but insulin resistance, the other thing to note, and this is why I have such a bias for stimulating the neuromusculoskeletal system, is that insulin resistance often begins in the muscle. So, and I believe this is the work of Gerald Schulman and Peterson et al. I'll find that it's knocking around on my hard drive somewhere. I'll find it and I'll put it in the show notes. After just one resistance training exercise, you can help reverse some of the insulin resistance that has settled into the muscle. Because just like Alzheimer's doesn't just show up one day when you're 80. It's been going on since you were like 20 or 30, years of age. The same is true for insulin resistance. This is happening in our 15-year-olds, our 25-year-olds, our 35-year-olds, et cetera. And without kind of going into the details, but I can, if you will, in a future episode. So please let me know in the comments. I can actually talk about the mechanisms in terms of why that's happening. If you guys want to know about like autophosphorylation and the GLUT4 receptor and all of that, but I'll spare you for now. But if you want more details on this, please let me know. And I'm happy to do another podcast episode on insulin resistance and like the mechanisms around it. Okay, let's get off this slide. Let's move to this one. So for women, fasting is clearly different. So I've been talking about some of the benefits to fasting in terms of hormones, some of the sexual dimorphic presentations like the liver and clotting factors, growth hormone, et cetera. But this is a big but. A woman, obviously, with her menstrual cycle, has this ever-changing hormonal milieu. You've heard me say before, men are like the sun, women are like the moon, right? Men are kind of circadian in their nature, meaning that they're kind of the same every day, right? It's like the sun rises and sets kind of at the same, level in the sky, maybe changes through like certain seasons or what have you, but pretty consistent, right? Women, more like the moon, right? So we kind of ebb and flow. Instead of that circadian daily rhythm, we sort of stretch our rhythm out over the course of about 29.5 or so days for most of us. That's the mean, is 29 and a half days for a menstrual cycle. And for women in their reproductive years, of course, we cycle over that course of that 29.5 days. We're cycling through periods of high estrogen, then low estrogen, then high testosterone, then low testosterone, then high progesterone, then low. And generally, actually, just building on the insulin sensitivity conversation, we are generally more insulin sensitive in the follicular phase of our cycle than we are in the luteal phase. Meaning, and that's actually directly due to progesterone. So progesterone decreases, okay, I'm not going to bore you too much with the details, but I will just tell you this, decreases the phosphorylation of glucose into glucose 6-phosphate, okay? So as such, right? So basically in the luteal phase of the cycle, we are more insulin insensitive. We behave more insulin resistant in the second half of our cycle under the influence of progesterone. So as a general rule, if you're someone who really does enjoy fasting, or you need to fast for, let's say you might have PCOS or you have a thyroid condition or, whatever, a general rule is going to be that aggressive fasting, so longer fasts, are better or more tolerated, we'll say, in the follicular phase of your cycle versus the luteal phase. And in the luteal phase, they should be gently They should be gentle, 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 gentle. Okay. The other thing we want to consider, of course, is that if we are aggressively fasting over a long delta, we will also see more masculinization, meaning that women are going to stop ovulating if it's done too aggressively, and they will stop menstruating. Okay. So this is, I may or may not have talked about my experience. I think I've talked about my experience of competing in figure competitions. And I got my body fat so low. It was 8 point something. It was like 8.3%. That is not normal. Okay. I lost my period. I was amenorrheic for a good, probably 3-4 months. And then when it came back, it was like, it was bad. It was bad news bears. So if you are aggressively fasting, and I would also categorize like overly calorically restricting in there as well, you are going to lose your menstrual cycle. Okay, which is for women a vital sign. If you are a woman, even in perimenopause, even if the shop is closed, ladies, and there's no more babies to be had, your job is to optimize for that fertile cycle, as wonky as it might be. Okay. The other thing I wanted to mention, this was actually a study that just came out this month, October 20. Well, actually, I guess it'll be last month now, 22. They were looking at fasting on some of the sex hormones in obese females. And this was done by Krista Verde. She's a professor of nutrition at Chicago. This was published in Obesity in October 22. And basically they followed a group of pre and post menopausal obese women for a period of 8 weeks. And they followed what's called the warrior diet. And this is like a method of intermittent fasting. Basically, the warrior diet prescribes a time restricted feeding window of about 4 hours a day, during which dieters can like kind of eat. They don't have to count calories, but they have 4 hours to eat. And after that 4 hours is done, they kind of go back to a water fast until their next feeding time. And what they found was DHEA. I spoke about this with my conversation with Nicole Jardim. This is, I think Nicole called it like the mother hormone or the pro hormone. It was something cute like that. It was like the mother hormone. This is the hormone that gives rise to progesterones and estrogens and testosterones, et cetera, was decreased in both the premenopausal and postmenopausal woman at the end of the trial by about 14%. Now, if you're a woman who's tried, let's say, getting pregnant, maybe you've been to a fertility clinic, you know that you've been prescribed DHEA because it is a hormone that improves fertility, and it also improves egg quality as well. So 14% drop in 8 weeks, even though the values of that study, like, the researchers noted that, it dropped 14% rather, but that was still the 14% that it dropped was still in normal range. I'd argue that, with the amount of women that I've seen, people don't just fast for 8 weeks and then abandon it, right? It's like, oh no, I'm fasting all the time and I'm going to make it harder and harder and harder for myself. That's kind of, when we typically see this more orthorexic type of behavior. So women don't just fast for 8 weeks, right? Like, women in many cases are like flamingos. They mate for life. It's like, I am all in for this because it worked a little bit for me in the beginning. So I am going to do it more and more and more. Okay. So these are some of the maybe cautionary, ways that we want to think about fasting for women. We want to make it like overarching premise here is that we want to make sure that it's gentler. We can't do it like our male counterparts can. The only exception I would say is that women in their menopausal years, if we work up a proper fasting tolerance and it's not too aggressive, actually can fast a little bit more aggressively than their perimenopausal, let's say, or women in their reproductive years, in those female counterparts, because their bodies, and of course, there's no disrespect that's meant here. It's just sort of what it is. Like menopausal women don't actually need to optimize anymore for a fertile cycle, like a fertility cycle. They're free from that. They have been freed from the golden chain, so to speak. So menopausal women in many ways can behave more male in that they can fast more aggressively. They don't have to take a break for 2 weeks in the luteal phase, let's say, because they don't have that anymore. Okay. So when I think about fasting, and this is what I was presenting the other day, I think of fasting as like three levers, right? So we can manipulate the type of fast. So there's several different types. We can manipulate the duration, like how long it is, and how often. So the frequency. So I like to think of fasting as like, what's the type? What's the duration? What's the frequency? And each lever can kind of be, manipulated based on the hormonal composition of the woman and whatever the desired outcome might be. So the first, and I write about this actually in the Betty Body in detail, is something that I refer to as a non-caloric liquid fast. So this is like water, coffee, teas. This is really great. So my ladies with PCOS, this is like super duper fabulous for you because it is one of the best ways to reduce hyperinsulinemia, which is an elevated state of insulin in the blood. And with fasting, kind of like keto, where we're kind of restricting one group, right? And with the ketogenic diet, we're restricting the carbohydrates. With fasting, we're restricting everything. We're restricting everything. The nutrient sensing pathways like insulin, right? These insulin levels are going to fall. And over time, when we apply a fasting strategy, let's say for a woman with PCOS consistently, this is going to help her improve that insulin sensitivity at that cellular level. Another type of fast is something that I call a caloric liquid fast. So like the name suggests, it's liquid, but it has calories. This would be where the fasting Puritans will be like, that is not a fast, but it is in Stephlandia. So I do think that this is very important for gut health. This is for my ladies who have estrogen dominance. And I will clarify that meaning that estrogen dominance in the luteal phase of her cycle. So there are times in the cycle where you need estrogen to be dominant. In the follicular phase, you need a big ass surge of estrogen or else that follicle is not developing. So we need estrogen dominance in the follicular phase, but we absolutely do not want it in the luteal phase. We want progesterone to be the dominant hormone. And when you have progesterone in adequate quantities, of course, it's going to downregulate estrogen receptors and downregulate estrogen secretion, et cetera. But for some women, that relationship goes awry. So we have estrogen dominance relative to progesterone in the luteal phase of the cycle. Bone broth fasting, or this caloric liquid fast, is a really beautiful solution that I have found clinically works very, very well for my ladies with estrogen issues. And part of that is it is going to help repair the epithelial lining of the gut. It's going to help reduce leaky gut issues, GI distress. And of course, a lot of times with women with estrogen dominance, one of the problems that we run into, there's kind of two main problems. One is their liver detoxification, or their, maybe said another way, like their metabolism of estrogen, which is done via the liver, is not optimal, right? So their conjugation, or their hydroxylation and conjugation, which I won't get into now, but those are kind of the two main phases of detox. Then we have elimination. So we have the liver, there's an issue with the liver. And then in the estrobolome in the gut, so this is like the microbiome that's dedicated to helping get rid of estrogen, has also gone awry. So a caloric liquid fast, like a bone broth or like soups, that kind of thing. Even like, matcha, or like, adding a little bit of calories to, let's say, your coffee, maybe with some cream or something, fatty coffee, fatty tea, that kind of thing. These are very, very helpful for women with estrogen dominance. And it also helps with healthy bowel movements. And y'all know, especially my ladies, my menstruating ladies, one of the best things about getting your period, the period poops, right? So we want healthy bowel movements. healthy BMs, nothing better. And Sara Gottfrield and I were talking about this when she was on the show. And she said, gosh, how did she say it? She said it's so, I'll put a link in the show notes. The way she said it was so funny. It was like, you want your bowel movement to be like an Olympic dive. You want it to be straight, one piece, and like hits the toilet with like minimal splash. And I was like, yes. Really well done, Sara. So, okay. So those are kind of the two ways that I like to think about fasting in terms of type. So we have non-caloric, caloric. So when we're talking specifically about, your period. Okay. So, when we have these period problems, right? PCOS, estrogen dominance, if we have time on this episode, we'll get into thyroid and leptin resistance and all the things. But your period starts in your brain, ladies. It starts with the release of follicular stimulating hormone and luteinizing hormone. And one of the clinically salient signs, or let's say yellow to red flags, in my opinion, is the ratio of those two hormones with each other. So if you're watching my video on YouTube, you'll see that I have an image of the pituitary gland here. And this is where we see release of FH, the hypothalamus and pituitary gland. We see release of FSH, follicular stimulating hormone, and luteinizing hormone. And the normal ratio, normal ratio stuff should be like 1:1. We measure this on day 2 or 3 of the cycle. If you are a woman and if you're like, listen, I don't get my period all the time. Sometimes I miss it. Sometimes I don't. I got hair on my chin. I have thinning hair. Maybe we want to also look like we want to look at day 2 or 3 of your menstrual cycle. So you're bleeding, right? So you want to look at LH and FSH. The normal ratio should be 1:1. Okay. A woman with PCOS, this ratio is definitely going to be disturbed. So we're going to have luteinizing hormone rising like 2 to 3, I've even seen higher on labs, higher than FSH. Okay. So you're going to have this 1:1 ratio, LH to FSH, completely disturbed. Many times, this is because insulin levels in the body are too high. We've talked a little bit about insulin already. There are other reasons that I won't get into now, but like hyperprolactinemia might be another reason why we see that disturbance, which is like higher levels of prolactin that are causing an increase in luteinizing hormone secretion. My ladies who, if you're a practitioner and you're in the Estima certification program, or you're thinking about it, or you will very shortly know that we talk a lot about genetics in the genetic predisposition. With PCOS specifically, we do see an increase in SRD5A2 activity, which is 5-alpha reductase. So it's basically like the testosterone to like super testosterone, the dihydrotestosterone. There's an increase in that gene expression. That increase in expression, those metabolites also inhibit estrogen production as well. So when we think about kind of clinically what a woman with PCOS might look like, so if this sounds like you, get yourself start tracking your cycle, and maybe we want to look at your LH and FSH ratios. You're going to think like a woman is going to be overweight. It's going to be very difficult for her to lose weight. We might see her body acting more male-like. So that ectopic fat distribution, like that extra weight through the abdomen. She might have like hair growth, let's say chin and cheek area, chest, back. She may have that hair loss, like I was saying, that kind of mimics like male pattern baldness. So there might be like a patch kind of at the back of her head. She might have thinning of the temples as well. So when we're thinking about PCOS, I mentioned non-caloric liquid fasts. What happens essentially in PCOS is that the hyperinsulinemic state doesn't it prevents the ovarian follicles from reaching ovulation. Okay. So the woman doesn't ovulate. And in case I haven't said it 1,000 times before. I'll make sure that I say it here again. The main point of your cycle is to ovulate. It's not to bleed. Okay. We want to optimize for ovulation. So that's why a woman with PCOS might have like irregular periods or non-existent periods as well. And this is by far the most common hormonal derangement. Like as a clinician, it is by far the most that I have seen in practice with women. Certainly estrogen dominance and Hashimoto's thyroiditis are like a close second. But the data that I have is like 100 million women worldwide. Like, that's a number, eh? Like that's a number, like 100 million women worldwide. It is the most common endocrine disorder of women of reproductive age. And it is the leading cause of ovulatory infertility. I mean, it's a number, man, like 100, like I don't even like, if we just looked at the states, that's a third of the states. Like that is just an incomparable number. And so we really want to be aware of some of the clinically salient signs, right? So some of the things I just described, like the body is sort of behaving more male, irregular, infrequent periods, that kind of thing. For a woman like this, I really like to use that non-caloric liquid fast. And I also like to, so it's like just the water, just the coffee, just the herbal teas, let's say. And then if she doesn't know where she is in her cycle because it's been months since she last had one, then you just start where you start. Like you just start increasing her fasting tolerance, and you may start like a 12-12, maybe you do a 14-10. I really like for a woman with PCOS, if we can kind of get a sense of where she's in her cycle. And this is not everybody, but I will say it's many women that I've worked with PCOS. I will fast. They will have a 24-hour fast 1 to 3 times a week, depending on the severity. And I usually front load that in the follicular phase because it's easier for her to do, but I will continue it in the luteal phase as well because of the just marked insulin resistance. And we're just trying to get it under control. And I'll probably do that for a couple of cycles until we start being able to predict with a little bit more accuracy where she is in her cycle, that she's bleeding. And then we're looking at other things like cervical fluid and all the other stuff. Okay. So what I'll do is I'll talk, I actually said this to the staff at Oxford. I was like, guys, I totally over prepared for this. I have like a 4-hour presentation and I only have 45 minutes. So maybe what I'll do is, I will cover estrogen dominance, because that is again, like a very common thing that we typically see in practice. And you are probably a woman who, if you've experienced any kind of PMS, you probably want to hear this as well. And then maybe next week, what I'll do is I'll continue with this fasting topic, but I'll go into a little bit more detail with like leptin resistance, Hashimoto's thyroiditis, and some of the other considerations that we might make for those populations. Okay. So estrogen dominance. I love this image. If you're watching this on YouTube, this is, a hormonal imbalance. It can cause like mood swings and depression and weight gain. And I remember when I was healing in my own journey, like I called my breast like angry breasts. Like t-shirts bothered everything. Like I didn't want anything. It kind of reminded me actually when I was breastfeeding, I remember the first kind of early days of breastfeeding, like anything touching my areola, like anything touching my nipples, it was like, oh my God, they're on fire. And it's kind of estrogen dominance kind of feels like that. And I mentioned already that it's not estrogen dominance throughout the cycle. It's just in the luteal phase. We want progesterone to be the main hormone of the sex hormone of the luteal phase of the cycle, not estrogen. So one of the things that I typically focus on with estrogen dominance is liver, like a sluggish liver, possibly where we're looking at augmenting hydroxylation and conjugation, which is just 2 fancy words for metabolizing estrogen properly, and then sending it into the gut and working on gut health so that we can get rid of the, the estrobolone can effectively get rid of estrogen. Like the golden rule of estrogen is use it and then lose it. And so what I will typically do with a woman with estrogen dominance is we will typically fast, kind of opposite to PCOS. So PCOS is like aggressively faster in the follicular phase of the cycle, get that FSH to LH ratio kind of on point. With an estrogen dominant woman, I'm probably going to be fasting, giving her a caloric liquid fast in the luteal phase of her cycle, because that's when we run into the most problems, right? So we will give her again, depending on severity, every patient is every woman is a little different. But we might be giving her 1 to 4 days, 1 to 3 days in most cases, a feeding window where we are, restricting her calories that day. And what she's having is those calories coming through her soups. It can be the bone broth, as I mentioned. It can also be minestrone and broth based soups. Sometimes I'll have chicken soup without the rice, let's say, for a woman. So it'll be boiled chicken, let's say, in a bouillon, boil some water, put a little bouillon in it. If you don't have your own bone broth, you can add the bouillon cube, and then some pulled chicken, maybe a little bit of rice as well. That's fine. So you're getting calories, but it's like a caloric restricted model where we're trying to help with gut health and with liver detoxification as well. Okay. So I hope that you have found some value here. I didn't quite get through leptin, didn't quite get through thyroid. This was a bit more of a technical episode. So this is just me kind of nerding out a little bit harder than maybe you have heard with like interviews or whatnot. But this is who I am. So I would love to hear what you're thinking about this format. I'm going to have a few more that I'm preparing for you over the course of the month. And I hope that you really enjoy it. And I would love if you want to leave a review on iTunes. We read all of them, good, bad, ugly. Certainly if you're enjoying the show, we always want to hear that. If there's ways that we can improve the show, we want to hear that as well. In a constructive manner, of course. Please don't shout at me in caps. Well, actually, you can do whatever you want. You can shout at me in caps if you'd like. Anyhow, so I hope that you enjoyed this. And next week, we'll continue the rest of this lecture series on fasting for women and how we can apply it to different hormonal derangements, let's say. And yeah, looking forward to talking to you soon. Bye for now. In this next video, Dr. Sara Gottfrield and I are talking about keto for women and why it is exquisitely different for us. We are talking in this next video about the testosterone advantage, cortisol, and the way that you can do keto right as a woman. Click over here and I'll see you there.
It's not a blanket statement that keto is good for everyone. I want to be sure that comes through loud and clear, because we have to personalize